Welcome to the Funnel Effect. Today we are undertaking a really critical, highly focused deep dive. We're looking into monumental new guidance in specialized cardiology. That's the 2025 ESC Guidelines for the management of cardiovascular disease and pregnancy.
It's a really comprehensive document, yes, and it comes directly from the European Society of Cardiology Task Force, co-chaired brilliantly, I should add, by Julie de Backer and Christina H. Haga.
Absolutely. So this is a deep dive driven by, well, necessity, right? What's our mission here today?
Yeah, urgency is the word. Our goal is really to break these guidelines down, to move beyond, the very technical language.
We did the practical stuff.
Exactly. Extract the crucial, actionable updates. We're specifically looking at how this new framework, it radically shifts care towards highly personalized expert management, particularly for women navigating pregnancy with pre-existing or maybe newly acquired heart conditions.
Okay. And we'll be focusing on things like the multidisciplinary approach, the updated risk scoring, and those specific management strategies.
Precisely. Drugs, delivery, the whole picture. How these expert teams are aiming to really improve risk assessment and patient outcomes, moving beyond a sort of general approach to highly personalized care.
Okay, let's set the scene then. The previous guidelines were from 2018. In high-stakes medicine like this, 7 years. That feels like a lifetime ago.
It really does.
What were the core changes, in research and demographics that made these 2025 updates not just, nice to have, but absolutely essential?
Well, the field has genuinely transformed since 2018. I think primarily it's due to the maturation of these big international registries like ROPAC.
The real-world data.
Exactly. They provide just vast amounts of real-world data we didn't have consolidated before. So these guidelines needed updating because the clinical focus itself has broadened quite significantly. We understand now, much more clearly, that care can't just start at the first antenatal visit. That's too late for many.
Right. You need to be ahead of the game.
Way ahead. We need explicit strategies for pre-pregnancy counseling, much more refined tools for risk stratification, you mentioned that, and also incredibly detailed guidance on drug management, both during pregnancy and lactation, which was often overlooked, and a far, far greater emphasis on the postpartum period. Historically, that was a bit neglected, wasn't it?
Definitely. It felt like once the baby was out, the focus shifted entirely.
But the risk doesn't start then, as we'll see.
And the demographics driving this, it's impossible to ignore, isn't it? We're talking about a growing population of women entering pregnancy with quite significant cardiac histories.
Exactly right. We're seeing a significant and sustained increase in pregnancies among women with acquired heart disease, congenital conditions, ACHD, or inherited CVD.
Why is that?
Well, part of it is simple social change. Women are choosing to have children at a later maternal age, generally. But I think the bigger factor, and this really speaks volumes about modern medicine, is that improved survival rates. Surgical, medical mean women with complex congenital heart disease are surviving well into their childbearing years.
Which wouldn't have happened decades ago.
Not consistently, no. But their conditions, even if stable, pose a unique set of challenges under the immense stress of pregnancy.
That brings us neatly to the core epidemiology. And I think these statistics, they can shock even experienced clinicians, can't they? When we talk about CVD complicating pregnancy, what sort of numbers are we dealing with?
Globally, the figure is up to about 4% of all pregnancies are complicated by some form of cardiovascular disease.
10%, okay.
But if you broaden that definition, as the guidelines suggest, to include hypertensive disorders like preeclampsia, that number can potentially soar up to 10%.
1 in 10 pregnancies potentially affected.
Potentially, yes. But here's the most alarming data point, the one that really mandates this intense focus. Maternal CVD is now the leading cause of non-obstetric mortality in pregnant women.
Leading cause. More than hemorrhage or infection.
Yes. It accounts for a shocking 33%, a third of all pregnancy-related deaths worldwide. It has completely eclipsed those traditional causes.
33%.
Yeah.
That's just a horrific statistic. But the sources immediately offer a counterpoint, don't they? A ray of hope that kind of provides the whole mandate for these new guidelines.
That's right.
We're told a huge majority of these deaths, they're actually preventable.
That is the pivotal insight. It's startling, really. The studies emphasize that 68%, over two-thirds of pregnancy-related deaths caused by CVD, are preventable.
Wow. Preventable how?
Because they often stem from identifiable system failures. Things like fragmentation of care between specialties, poor initial risk assessment, a lack of optimization before conception, or simply inadequate follow-up, especially postpartum.
So these guidelines aren't just describing risk.
No, they're providing the structural blueprint, the mandatory team approach, the specific protocols. They're designed to prevent those specific failures. And remember, even aside from mortality, for women with pre-existing CVD, adverse neonatal outcomes already happen in about 25% of pregnancies. And maternal mortality or serious morbidity rates hover around 11%.
So the data just screams for this kind of coordinated expert care.
It insists on it. It's become a matter of public health urgency.
Okay, before we dive into how care is structured now, let's just touch on the why, the mechanism of risk. For the listener who's curious about the mechanics, what are the fundamental physiological demands pregnancy places on the cardiovascular system? What exactly is the heart adapting to?
Well, the system starts adapting almost immediately. We're talking as early as 6 weeks of gestation.
6 weeks? That early?
Yes. The primary goal is to support the growing uteroplacental unit, and this requires a significant expansion of plasma volume. The amount of fluid in the blood goes up. This leads directly to increased stroke volume, the amount of blood pumped with each beat. And crucially, cardiac output, the total amount of blood pumped per minute, starts rising dramatically. It peaks mid-pregnancy, maybe 30% to 50% above the woman's baseline.
50% increase. That's huge.
It is. You can almost think of it like the body running a continuous low-grade marathon, 2047, for months. It requires constant high output.
And if the woman has a pre-existing cardiac condition, maybe a narrowed valve, a weakened ventricle, something like that, how does this continuous marathon demand cause things to go catastrophically wrong?
Well, a compromised heart might just about manage baseline cardiac output, day-to-day life. But it simply may not have the reserve to handle that extra 30–50% volume load effectively. Suboptimal adaptation to this increased demand. That's what triggers the severe complications.
Like what? What's most common?
The most common is heart failure. It can develop quite suddenly, be very dramatic. But we also see a significantly increased risk for other life-threatening events, like aortic dissection in women with underlying aortopathy conditions like Marfan syndrome. The wall of the aorta is under immense pressure and sheer stress from that extra volume and flow.
Makes sense.
And furthermore, the volume changes, combined with activation of the sympathetic nervous system, increase the propensity for arrhythmias. We see more atrial fibrillation or even dangerous ventricular tachyarrhythmias.
So it's not just the sort of plumbing under pressure, it's the electrical system too. And the chemistry changes as well, doesn't it? How does pregnancy change the way a woman's body processes medication? This seems critical for managing chronic conditions.
You've hit on a really major point there. Pregnancy fundamentally changes drug pharmacokinetics, how the body handles drugs. Essentially, it speeds up clearance for many medications.
Speeds it up.
We see increased hepatic metabolism. The liver is just working overtime processing things. And significantly higher glomerular filtration rates in the kidneys. They're filtering the blood much faster.
So drugs get broken down and excreted more quickly.
Exactly. You also have changes in plasma protein binding because serum albumin levels tend to decrease, which can affect how much free drug is available. All of this together can lead to lower effective drug concentrations in the bloodstream.
Which is a problem if you need stable levels.
A huge problem. If a woman is reliant on stable levels of long-term medications, think immunosuppressants after an organ transplant, or crucial antiarrhythmic agents, the dosing strategy often needs continuous adjustment and monitoring throughout the pregnancy just to maintain therapeutic levels. It adds another layer of complexity to the whole management plan.
Okay, so if the problem involves multiple systems, cardiac, obstetric, hematologic, pharmacology, the solution logically has to be multidisciplinary.
It has to be.
And the 2025 guidelines really formalize this by mandating the existence and involvement of the Pregnancy Heart Team, the PHT. You mentioned this was sort of a general principle before.
It was more of a good idea, a recommendation.
Right. Now it's codified.
Yeah.
How is the PHT actually structured? Who are the core players on this team?
Yeah, the new guidelines really elevate the PHT. It goes from being a general principle to a dedicated, mandatory, and quite specialized structure. The absolute core is multidisciplinary teamwork. It requires, at minimum, a cardiologist, ideally one who specializes in ACHD or maybe heart failure or cardiomyopathies, depending on the patient. Then an experienced obstetrician who really understands high-risk pregnancies. And a specialist anesthesiologist, they are absolutely vital for delivery planning and managing pain relief
Right.
simply.
That makes sense. Cardiologist, obstetrician, anesthesiologist.
But increasingly, the guidelines stress the team must also include others as needed. Geneticists for inherited conditions, specialist nurses who often coordinate care, and crucially, dedicated psychosocial support professionals, counselors, psychologists.
That psychosocial piece feels really important given the stress involved.
It's huge, so it's an integrated unit. And the key is that it follows the patient right from before conception through pregnancy, delivery, and critically into that postpartum period.
What are the primary mandated responsibilities of this team? It sounds less like a committee that meets occasionally and more like a continuous management unit.
That's exactly the idea. Their responsibility is comprehensive, end-to-end. It starts with that personalized risk assessment using the new MWHO 2.0 tool we'll discuss. Then, they collaboratively develop the detailed care plan, they manage all the medication adjustments, continuously monitor the patient's clinical progress.
And educate the patient.
Intensive patient education is key. And that psychosocial counseling we mentioned dealing with a high-risk diagnosis during pregnancy requires so much more than just medical management. The PhD has to ensure this whole sequence of care flows seamlessly. Preconception, pregnancy, labor, delivery, postpartum, no gaps.
The sources are very specific about when this PhD involvement becomes mandatory. It's not just reserved for the absolute most complex, desperate cases, is it?
No, and that's a key update. It's really important for driving that preventability aspect we talked about. The guidelines give a Class I recommendation, meaning it must happen. It's the strongest level of evidence that any woman with CVD classified as MWHO 2.0 Class 2-3 and above.
So intermediate risk and higher.
Correct. Intermediate to extremely high risk. They must be evaluated and managed by a pregnancy heart team. And crucially, this involvement has to start from the pre-pregnancy consultation stage, if possible, and continue right through the postpartum period.
That really aims to prevent that fragmentation of care that historically led to bad outcomes.
Exactly. Now, for patients with simpler, genuinely low-risk lesions, the MWHO Class I group consultation with a specialist is still advised, but the full mandatory PHT-led management isn't necessarily required for everyone in that group.
Okay, let's talk about what must be the most difficult conversation. The counseling for the highest risk group, that's MWHO 2.0 Class 4. This is where the risk of maternal death is alarmingly high.
Yes.
And the concept of shared decision-making is really tested to its absolute limits here, isn't it?
It is. For women classified as MWHO 2.0 Class 4, we are talking about conditions where the maternal mortality risk can exceed 25%, and for some conditions, the combined morbidity-mortality event rates are over 50%. It's incredibly dangerous.
So what's a PhD's responsibility there?
Here, the PhD has an explicit mandatory responsibility to discuss the extremely high risk of both maternal mortality and severe morbidity, very frankly. And this discussion must include shared decision-making regarding the option of pregnancy termination.
That's incredibly sensitive territory.
Extremely. And this is precisely why the guidelines explicitly stress the necessity of involving professional psychological support right from the start of this conversation. The emotional and psychological impact of being advised against pregnancy or facing this incredibly difficult choice, it's immense. The PhD must ensure the decision is truly informed, genuinely shared, fully supported, and absolutely not coerced in any way.
A huge ethical responsibility for the team.
Massive.
Now, to optimize outcomes, the guidelines insist this whole process, ideally, begins before conception. How does the PhD structure that pre-pregnancy counseling and family planning stage? What are the goals?
Pre-pregnancy is really seen as the golden window for optimization. It's the stage where the PhD has the most control to actively reduce risk before the physiological stress of pregnancy begins. The goal is a highly personalized risk assessment that looks way beyond just the primary cardiac diagnosis.
What else do they look at?
They consider the woman's functional status, her NYHA class, how she feels day to day, her current medications, switching out any teratogenic drugs harmful to the fetus is absolutely paramount at this stage. And they also factor in non-cardiac risk factors, things like maternal age, body mass index, BMI, smoking status, even socioeconomic factors, which we know can affect adherence to complex medical regimens.
So it's a truly holistic assessment.
Yes, designed to ensure the patient enters pregnancy, if she chooses to proceed, in the absolute best possible condition.
Many of these women might need help conceiving, perhaps requiring reproductive technology like IVF. Does having CVD inherently reduce fertility? And what specific risks does the fertility treatment itself pose?
That's an interesting point. For most women with CVD, their underlying infertility rates are actually quite similar to the general population. Having heart disease doesn't automatically mean you can't conceive naturally.
Okay.
However, the management of medically assisted reproductive treatment, like IVF, is significantly more complex and potentially risky for them.
Why is that?
The primary concern is the volume load associated with stimulating ovulation and the potential for multiple pregnancies. For this reason, the PHT delivers a very strong Class I recommendation for single embryo transfer in women with CVD.
Single embryo transfer only. Why?
Because a twin, or, heaven forbid, triplet gestation dramatically increases the cardiovascular workload. It pushes cardiac output demands well beyond the compensatory range of an already compromised heart. It can be catastrophic.
Right. Avoid multiples at all costs.
Essentially, yes.
And you mentioned a risk from the treatment itself.
Yeah.
Is there a chemical or hormonal risk associated with IVF, particularly for women maybe already on blood thinners or those in the higher MWHO risk classes?
Yes, that's correct. The process of superovulation, which involves using high doses of hormones to stimulate egg production,
Right.
that process is inherently prothrombotic. It slightly increases the background risk of blood clots forming.
Which is a serious danger for some of these patients.
A critical danger, especially for women who are already in MWHO class 3, or those who absolutely require therapeutic anticoagulation like someone with a mechanical heart valve. Therefore, the guidelines state that a full PHT pre-pregnancy assessment is absolutely required before initiating any fertility treatment. They need to weigh the hormonal risks against the patient's specific cardiac condition and potentially adjust their anticoagulant regimen temporarily, or maybe consider alternative lower-risk fertility methods like natural cycle IVF if appropriate.
Okay, so this entire system of mandatory PHT involvement, the level of counseling, the pre-pregnancy planning, it all hinges on accurate risk stratification.
Absolutely.
And the tool for that you mentioned is the Modified World Health Organization classification, now updated to MWHO 2.0. How does this system work, fundamentally? And why was the 2.0 update needed? What was wrong with the previous WHO system?
The previous iteration, the original MWHO, was certainly robust for its time, but it lacked a bit of granularity, especially in that crucial middle risk category. It sometimes lumped together patients with quite different prognosis.
Yeah.
So the 2025 guidelines introduced the MWHO 2.0 classification. This is a refined and significantly expanded set of clinical categories. It's designed to move beyond just a simple risk score towards a deeper, more clinically actionable categorization of patients. It provides a highly nuanced assessment of the potential risk for both maternal mortality and severe maternal morbidity during pregnancy and the peripartum period.
And the main change was splitting a category.
Yes, the core update was the split of the original combined Class 3 category into two distinct classes. Class 2, representing low to moderate risk, and Class 3, representing moderate to high risk.
Why was that split so important?
Because it explicitly recognizes that the management, the intensity of monitoring, the counseling, it's fundamentally different for a woman with, say, mild valve disease versus someone with moderately impaired heart function. They shouldn't be in the same risk bucket. This split allows for more tailored care pathways.
Okay, that makes sense. Let's define these 5 classes then with some concrete examples so you can really understand the difference of the risk profile we're talking about. Starting at the bottom, MWHO Class 1.
Right. MWHO Class I represents the lowest risk group. Think of women with successfully repaired simple congenital heart lesions. Things like an atrial septal defect, ASD, a ventricular septal defect, VSD, or a patent ductus arteriosus, PDA. The key operative word there is successfully repaired, meaning there are no significant residual complications, no leftover valve issues, no pulmonary hypertension, and importantly, good ventricular function.
So their risk is basically baseline.
Essentially, yes. Their maternal mortality risk is considered very similar to that of the general pregnant population, minimal increased risk.
Okay, now where do we start entering that gray area, the zone that requires that mandatory PHT involvement we discussed?
We enter that critical zone starting with MWHO Class 2 and then moving into the newly defined Class 2-3. So Class 2 might include conditions like, say, mild left ventricular dysfunction where the ejection fraction is still pretty good, maybe above 45%, or perhaps mild forms of valve disease that aren't causing major problems, still needs specialist oversight, but lower risk.
And Class 2-3, that's the intermediate to high risk group.
Correct. Class 3-3 is where PHT management becomes mandatory. This category now includes women with moderate left ventricular impairment, specifically defined as an ejection fraction, EF, between 30% and 45%.
Okay, EF 30 to 45.
Right. It also includes certain complex but currently well-compensated conditions. A key example given is an uncomplicated Fontan circulation, meaning someone who had that complex surgery but currently doesn't have significant complications like protein-losing enteropathy or severe cyanosis.
So that split between 2 and T3 is really vital clinically.
Absolutely vital, because the prognosis and the intensity of management required for someone in the free group are significantly different and generally worse than for someone in the straightforward 2 group. That justifies the mandatory team approach for 2, 3, and above.
Makes perfect sense. Finally, let's discuss the conditions that land a woman in MWHO Class 4. You mentioned earlier this is the group explicitly advised against pregnancy because the danger is just too high.
Yes, MWHO Class 4 conditions carry an extremely high risk of maternal mortality, potentially exceeding 25%, and in some studies, approaching 50% or more for combined mortality major morbidity.
Just incredibly high stakes.
They are generally considered conditions incompatible with a safe pregnancy outcome for the mother. Key examples include: first, severe LV impairment. This is defined as an ejection fraction, EF, below 30%, or severe heart failure symptoms even with medication. NYHA Class 3 or 4. The heart simply lacks the reserve capacity to handle the pregnancy volume load.
Okay. Severe heart failure.
Second, pulmonary arterial hypertension, PAH, regardless of the cause. This is almost universally considered Class 4 because the pulmonary circulation cannot cope with the increased blood flow and volume. Labor and delivery in particular often trigger a fatal right heart failure crisis in these women.
Right. PAH is extremely dangerous.
Third, a specific genetic condition, vascular Ehlers-Danlos syndrome. This is an inherited connective tissue disorder that dramatically weakens blood vessels and tissues, increasing the risk of catastrophic arterial rupture or even uterine rupture during pregnancy or delivery.
Wow.
And fourth, Eisenmenger syndrome. This refers to complex, unrepaired, cyanotic congenital heart disease, where the patient has developed severe pulmonary hypertension as a consequence. Again, the PAH component makes pregnancy extremely risky.
It's crucial, I think, to connect these clinical conditions back to the hard data. The event rates provided in the source material, derived from those big registries like ROPAC, they really visualize the dramatic jump in risk across these MWHO classes, don't they?
They absolutely do. The data makes the risk stratification undeniable and clinically powerful. The average maternal cardiac event rate that's combined mortality and major morbidity for women in Class 1, as you'd expect, is low, around 3.1% in the studies cited.
Pretty low.
But as soon as you move into those intermediate categories, the risks escalate significantly. Class 2-3 sees average event rates that can climb up towards 21.7% in some cohorts.
Okay, so around 1 in 5 for 2-3.
Roughly, yes. But the transition to Class 4 is just stark. For that extremely high-risk group, the average maternal cardiac event rates jump alarmingly high. They range from 35.6% up to 50.3% in the reference studies.
50%. That Class 4 rate is essentially a coin flip on surviving pregnancy without a major event.
It is, and that gives profound weight and urgency to the PHT's mandatory counseling requirement for that group. This classification isn't just theoretical, it's a powerful predictive tool that must inform that shared decision-making process.
Okay, let's shift our focus now to the highly specific management strategies. What do the guidelines actually say about managing some of the most complex cardiac conditions during pregnancy? Let's start with cardiomyopathies, or CMPs. When a woman with a known cardiomyopathy approaches the PHT, what's the core management strategy they initiate, ideally before she even becomes pregnant?
Right. For cardiomyopathies, the absolute overarching principle is achieving optimal medical stabilization before conception. That's paramount. This involves making sure her guideline-directed medical therapy is fully optimized, making sure all medications that are contraindicated in pregnancy are identified and switched out well in advance. That's a critical step.
What drugs are we talking about there?
Well, the guidelines make a very firm stance on amiodarone, for instance. It's listed as strictly contraindicated in pregnancy due to the high risk of severe fetal thyroid toxicity. Others like ACE inhibitors, ARBs, ARNIs, SGLT2 inhibitors, we'll discuss later, are also out. And importantly, ensuring that if the woman meets the established criteria for needing an implantable cardioverter defibrillator, ICD, because of her risk of dangerous arrhythmias, that the ICD implantation is performed prior to pregnancy, not during. Getting her as stable and protected as possible beforehand is the goal.
Okay. Let's talk about hypertrophic cardiomyopathy, HCM. It's the most common inherited cardiomyopathy. While it clearly carries a risk of sudden death, how favorable are pregnancy outcomes generally for women with HCM, and what are the specific risks during delivery?
Generally speaking, pregnancy outcomes can be manageable for women with HCM, provided they don't have severe pre-existing symptoms. The absolute maternal mortality rate, fortunately, is reported to be quite low, around 0.5%.
Okay, low mortality, that's good.
However, complication rates are definitely real and need careful management. That ROPAC registry showed that about 23% of pregnant women with HCM developed major adverse cardiac events during pregnancy.
What kind of events?
Often things like worsening heart failure symptoms or arrhythmias, including non-sustained or even sustained ventricular tachycardia. The critical risk factors predicting these events are having advanced symptoms before pregnancy, being NYHA class 3 or 3.
And during labor and delivery, is there a specific concern?
Yes, the PH2, particularly the anesthesiologist, must be hypervigilant regarding left ventricular outflow tract obstruction, or LVOTO if the patient has it,
Why?
because any procedure that causes significant peripheral vasodilatation, meaning widening of the blood vessels, which lowers blood pressure, can be dangerous. The classic example is an epidural for pain relief. If blood pressure drops too much, it reduces the filling of the left ventricle. In someone with LVOTO, this can severely worsen the obstruction, leading to dangerous hypotension or even collapse. The anesthesiologist has to manage that balance incredibly precisely, perhaps using different pain relief techniques or very careful fluid management alongside the epidural.
A delicate balance indeed. Then there's peripartum cardiomyopathy, PPCM. This is a unique form of heart failure specific to pregnancy and the postpartum period. What's the current understanding of the mechanism behind PPCM, and how is the treatment evolving based on that?
PPCM is a really challenging diagnosis. It's essentially a diagnosis of exclusion, defined as new-onset heart failure with a reduced left ventricular ejection fraction, LVEF, below 45%, occurring either in the final month of pregnancy or, more commonly, within the first 5 months postpartum.
And the cause?
The current leading hypothesis points towards a mechanism involving the hormone prolactin, which is crucial for lactation. It seems that in susceptible women, prolactin can be cleaved, broken down into an abnormal, shorter fragment, a 16-kiloday prolactin fragment.
And this fragment is harmful.
Yes, this 16-kiloday fragment appears to be anti-angiogenic, meaning it damages blood vessels, and cardiotoxic. It seems to damage the endothelial lining of the small blood vessels within the heart muscle itself.
Interesting. Has this molecular understanding led to new treatments?
It has. It's paved the way for exploring an emerging, potentially disease-specific therapy, the dopamine D2 receptor agonist, bromocriptine.
Bromocriptine. How does that help?
Bromocriptine works by blocking prolactin secretion from the pituitary gland. The theory is that by reducing overall prolactin levels, you reduce the production of that harmful 16-kiloday fragment, potentially interrupting the disease pathway and allowing the heart to recover.
Is it standard treatment now?
It's still considered an emerging therapy. Its use remains complex, often reserved for more severe cases, and usually requires careful discussion within the PhD, especially balancing its potential benefits against potential side effects, like blood clot risk. But it represents a real step forward based on understanding the mechanism.
Okay, let's move on to aortopathies, conditions like Marfan syndrome, where the big risk isn't necessarily heart failure, but mechanical failure, rupture, or dissection of the aorta itself.
Right.
The source material contains a statistic about the timing of aortic dissection that you mentioned. Dramatically changes how clinicians need to think about monitoring after delivery. Can you elaborate on that?
Yes, this is a major insight from recent registries, and it absolutely must drive PHT behavior and patient counseling. While aortic dissection during pregnancy or postpartum is rare overall, the figure cited is about 5.5 cases per million women.
So very rare.
Very rare, but it carries exceptionally high morbidity and mortality when it does happen. The really surprising discovery is the timing. The data clearly shows that 62%, nearly two-thirds of pregnancy-related aortic dissections occur during the postpartum period.
Not during labor.
Only about 15% happen antenatally before labor. The peak risk isn't during the extreme physical stress of labor and delivery itself, but actually after the baby is born, often in the first week or so.
That seems counterintuitive. Why is the risk highest after the main stress is theoretically over? What's the physiological driver of that postpartum peak?
It does seem counterintuitive at first, doesn't it? But it's highly logical when you think about the hemodynamics. During pregnancy, although the volume load is high, blood pressure tends to be slightly lower on average, and the body has gradually adapted over months. Postpartum, however, you get rapid, massive fluid shifts. That huge plasma volume expansion up to 50% rapidly reverses as the body excretes the extra fluid. blood pressure tends to rise back to pre-pregnancy levels or sometimes even higher temporarily.
Wow, so sudden changes.
Exactly. This sudden hemodynamic normalization, this rapid change in volume and pressure, combined with hormonal shifts like the sharp drop in progesterone, which might impact collagen integrity in the vessel wall, creates peak mechanical shear stress on an already weakened or dilated aortic wall. That seems to be the trigger point.
Okay, that makes sense. So given this elevated risk, particularly for women with known conditions like Marfan syndrome, MFS, or other heritable thoracic aortic diseases, HTDs, what are the cornerstone management strategies recommended in the guidelines?
Two things stand out. First, beta blocker therapy is strongly recommended. It gets a Class I recommendation, meaning it's considered mandatory best
Throughout
practice.
pregnancy.
Yes, and critically, it must be initiated, if not already on it, and maintained not just during the 9 months of pregnancy, but throughout the entire high-risk postpartum period as well, specifically to reduce aortic wall stress during that vulnerable time. Second, proactive surgical management before pregnancy is non-negotiable if significant aortic dilatation is already present.
Hmm.
The guidelines provide quite specific pre-pregnancy surgery thresholds to guide the PHT and the patient.
What are those thresholds?
For Marfan syndrome, an aortic root diameter greater than 45 millimeters generally warrants consideration for prophylactic repair before attempting pregnancy. For women with a bicuspid aortic valve, BAV, which is also associated with aortopathy, the threshold for pre-pregnancy surgery is typically a bit higher, usually around 50 millimeters, although other factors are considered too.
And how do these aortic risks influence the choice of delivery mode? Is vaginal delivery safe?
The PHT has to individualize this decision based on the specific patient, her aortic size, and other factors. But generally, the guidelines suggest that vaginal delivery is recommended and can be safe if the aortic diameter is relatively small, specifically cited as less than 40 millimeters.
Okay.
With the important caveat that the second stage of labor, the pushing stage, should ideally be shortened, perhaps with instrumental assistance like forceps or vacuum, to minimize the straining and Valsalva effect, which acutely raises pressure.
And if the aorta is larger?
For larger diameters, typically greater than 45 millimeters, or if the woman has had rapid growth during pregnancy, or if she has a known history of a previous aortic dissection, then a planned cesarean section is generally considered the safer option to avoid the unpredictable stresses of labor.
And reflecting that high postpartum risk peak.
Yes, exactly. Reflecting that peak risk around day 6 postpartum, the guidelines now suggest that women with known aortopathies may require prolonged hospitalization, potentially for up to 1 full week after delivery, specifically for intensive blood pressure control and clinical monitoring during that highest risk window.
That's a significant change in practice.
It is.
Okay, finally in this section, let's consider adult congenital heart disease, ACHD. This is obviously a vast, incredibly complex category of conditions. Is the outlook uniformly high risk for all women with ACHD?
No, and that's a really important clarification to make. ACHD is increasingly common now, but the overall outcomes for pregnant women with ACHD are actually generally favorable. The ROPAC registry, for example, reported a very low overall maternal mortality rate, around 0.2%.
0.2%, that's very low.
Very low overall. However, the complexity lies in the huge heterogeneity within ACHD. It ranges from simple repaired defects with near normal life expectancy to incredibly complex physiology. The challenge for the PHT is identifying the minority of patients within that broad ACHD umbrella who face truly catastrophic risks.
So if the overall mortality is that low, does the data really justify the mandatory intensive resource allocation of a full PHT for all ACHD patients above Class 1? It sounds expensive.
That's a fair question, and the answer lies precisely in that huge variability of the risk profile within ACHD. While the average mortality is low, the PHT must intensely focus on specific, well-defined, highest-risk subgroups because their individual event rates can be shockingly high.
Which subgroups are those?
Key examples include women with a systemic right ventricle, RV. This is often seen after older repair operations for transposition of the great arteries, like the mustard or Senning procedures. Their RV wasn't designed to pump against body pressure, and it often fails under the strain of pregnancy. Another high-risk group is women with Fontan circulation, that complex single ventricle physiology we mentioned earlier, especially if they have complications.
And their event rates are high.
Yes. In some published cohorts, for example, looking at women with TGA after an atrial switch repair, mustard setting, the rate of major adverse cardiovascular events, MAE, which includes not just death but also stroke, Heart failure hospitalization, significant arrhythmia can be as high as 28%.
28% MAE.
Okay.
That's definitely high risk.
Exactly. It's that high ME rate in specific subgroups that absolutely drives the requirement for mandatory PHT management. It's about identifying and intensively managing those individuals. And consequently, there's also a strong class size recommendation that any woman with ACHD who has a significant unaddressed hemodynamic lesion, maybe a residual hole, a significant valve issue, should have guideline-directed intervention, like catheter closure or surgical repair, discussed and ideally performed prior to contemplating pregnancy, specifically to mitigate that risk. Optimization first.
Right, medication management for women with cardiac conditions during pregnancy. It's always a constant, delicate balancing act, isn't it? Trying to protect the mother's health without harming the developing fetus.
It's incredibly challenging.
The sources spend a significant amount of time on anticoagulation blood thinners, especially unpacking that really difficult trade-off between the older vitamin K antagonists, VKAs like warfarin, and the newer low molecular weight heparins, LMWH.
Yes, this is perhaps one of the most complex and high-stakes areas of management discussed in the guidelines. The fundamental trade-off is very clear, but the decisions are tough. VKAs, like warfarin, are generally highly effective at preventing maternal thrombosis, especially dangerous blood clots on mechanical heart valves. That's their strength.
But the downside?
The huge downside is that they easily cross the placenta and carry a significant risk of causing harm to the fetus. Specifically, warfarin embryopathy causing birth defects, particularly if exposure occurs during the critical first trimester between 6 and 12 weeks gestation. There's also a risk of photopathy and bleeding later in pregnancy.
Okay, so VKAs are effective for mom, risky for baby. What about LMWH?
Low molecular weight heparin is the opposite profile. Its major advantage is that it does not cross the placenta, making it far safer for the developing fetus. But the evidence suggests it may be less effective than warfarin at preventing thrombosis in certain very high-risk situations. The most critical example, mentioned repeatedly, is in women with mechanical heart valves, MHVs. There is a higher risk of valve thrombosis, which can be fatal for the mother when using LMWH compared to well-managed warfarin.
And women with these mechanical heart valves represent the absolute highest clinical challenge for anticoagulation management, don't they? How specific are the guidelines for them?
They are extremely specific because, as you say, these women are uniquely high risk. The guidelines quote data suggesting the chance of a completely uncomplicated pregnancy resulting in a live birth for a woman with an MHV is only around 54%. That's incredibly sobering.
54% event-free rate.
Yes. So preventing maternal valve thrombosis is the absolute top priority. The guidelines therefore acknowledge a difficult reality. For women with MHVs who have a very high thrombosis risk, for example, older valve types, previous clot, continuous VKA use may be considered throughout pregnancy, including the first trimester.
Even with the fetal risk.
But only if the required dose of warfarin is low, specifically cited as less than 5 milligrams per day, as higher doses carry a much greater risk of embryopathy. And even then, it requires extensive counseling about the risks.
And if the dose is higher, or the patient prefers to avoid VKA in the first trimester,
then the general recommendation remains to switch to LMWH, usually given twice daily by injection. However, this isn't simple either. It requires extremely tight monitoring, not with INR like warfarin, but using specialized blood tests called anti-factor Xi levels, drawn at specific times after injection to ensure the dose is truly therapeutic. This monitoring can be complex and needs expertise.
a lot to manage. And what about the newest blood thinners, the DOACs, direct oral anticoagulants?
Here, the guidelines are absolutely unequivocal. DOACs get a Class 3 recommendation, meaning they are strictly not recommended and should be avoided during pregnancy.
Why?
Primarily due to a lack of robust safety data in pregnant humans and concerns based on animal studies and their mechanism of action about potential fetal harm. Until we have much more data, they are contraindicated.
Okay, so DOACs are out. Now, once that difficult 9-month journey managing anticoagulation is nearing its end, the PHT has to coordinate a planned delivery for these women, right? How is that transition from VKAs or LMWH managed to ensure a safe delivery without risking catastrophic hemorrhage?
Yes, planned delivery is absolutely essential for any woman on therapeutic anticoagulation. You cannot safely have spontaneous labor while fully anticoagulated. The anesthesiologist plays a key role in this planning.
So what's the process?
If the woman is on a VKA, warfarin, it must be discontinued well in advance, typically by the 36th week of gestation or at least 2 weeks before the planned delivery date. The patient is then usually switched to therapeutic dose LMWH injections. Critically, that LMWH must then be stopped at least 24 hours before the planned delivery, either induction or C-section, to allow its anticoagulant effect to wear off sufficiently.
24 hours for LMWH. What if you need a shorter gap?
If a shorter washout period is needed, perhaps for obstetric reasons, or if the patient is considered particularly high risk for thrombosis, even off anticoagulation for 24 hours, they might be admitted to hospital and transition to intravenous, unfractionated heparin UFH.
Why UFH?
Because UFH has a much shorter half-life than LMWH. It can be stopped just 4-6 hours before delivery, and importantly, its effect can be monitored easily with a test called EPTT and reversed more quickly if needed.
And this timing is crucial for anesthesia.
Absolutely crucial. Regional anesthesia, like an epidural or spinal block, which are often preferred for cardiac patients, cannot be safely administered if the patient is still anticoagulated due to the risk of spinal hematoma, a rare but devastating complication. So that timing window is non-negotiable.
What happens if an emergency occurs? Someone goes into labor unexpectedly while still on anticoagulants. What's the modern protocol for urgent reversal?
The PHT must have clear, immediately accessible emergency reversal protocols in place for this exact scenario. It needs to be drilled. If the patient is on heparin, either LMWH or UFH, the reversal agent is protamine sulfate given intravenously. It works quite quickly to neutralize the heparin.
Okay, protamine for heparin. What about warfarin?
If a woman requires emergency delivery while her INR is still high from warfarin, the guidelines now strongly recommend using 4-FPCC, that's 4-factor prothrombin complex concentrate.
4-FPCC, not just vitamin K or fresh frozen plasma.
Vitamin K takes too long to work in an emergency. Fresh frozen plasma, FFP, does contain clotting factors, but you need to give large volumes, which can be problematic in cardiac patients, and it takes time to thaw. 4-FPCC is the preferred modern agent because it provides a concentrated dose of the necessary clotting factors much faster with a lower volume load, leading to quicker reversal of the coagulation deficit. FFP is the backup if PCC isn't immediately available.
Good to know. And the restart of anticoagulation after delivery. That's also intentionally delayed sometimes.
Yes, the immediate postpartum period, especially after a C-section or if there were tears during vaginal delivery, carries a significant risk of bleeding, particularly late obstetric bleeding. So the PHT has to again balance the risk of maternal thrombosis, which starts to rise again once anticoagulation is stopped, against the risk of hemorrhage at the delivery site.
How is that decision made?
Heparin, UFH or LMWH, can usually be resumed relatively soon after delivery, perhaps 4-6 hours post-delivery for UFH, maybe 12-24 hours for LMWH. Once the obstetrician and cardiologist agree the immediate risk of surgical or obstetric site bleeding is deemed acceptable. However, the guidelines specifically suggest delaying the restart of VKAs, warfarin, until 7-14 days postpartum.
A week or two? Why so long for warfarin?
To ensure the VKA concentration doesn't reach its peak anticoagulant effect during that period of highest risk for late uterine bleeding, which can sometimes occur unexpectedly several days after delivery, it's an extra layer of caution.
Okay, moving beyond anticoagulation. What's the strategy for managing high blood pressure during pregnancy, either chronic hypertension or pregnancy-induced conditions like preeclampsia? What's a target BP, and which drugs are considered safest?
For hypertension in pregnancy, the general consensus reflected in the guidelines is to aim for a systolic blood pressure below 140 mmHg and a diastolic blood pressure below 90 mmHg. Tighter control doesn't necessarily improve outcomes and might risk reducing placental blood flow.
So keep it below 410/90. Which drugs are preferred?
The recommended first-line antihypertensive drugs are those with the most robust long-term safety data in pregnancy. These are primarily methyldopa, the beta blocker labetalol, and certain dihydropyridine calcium channel blockers, particularly nifedipine, usually in a long-acting formulation.
Okay, methyldopa, labetalol, nifedipine.
Those are the mainstays.
Now, beta blockers are obviously a cornerstone of treatment for many cardiac conditions, but you mentioned labetalol. Do other beta blockers carry a specific concern regarding fetal growth? What are the PHT's preferred and perhaps least preferred agents in this class?
Yes, this is an important finding highlighted again. The data, particularly from the large ROPAC registry, provides a clear picture here. Overall, beta blocker exposure during pregnancy is associated with a significantly higher rate of babies being born small for gestational age, SGA.
How much higher?
The rate was around 15.3% for babies exposed to beta blockers versus 9.3% in unexposed pregnancies in that registry. So it's a noticeable difference.
But they're often essential for the mother.
Absolutely essential for maternal health in many cases, like managing arrhythmias, HCM, or post-MI. So it's about choosing wisely. The guidelines suggest that labetalol seems to have a relatively lower associated SGA risk compared to others. They also mention that more lipophilic, fat-soluble beta blockers like propranolol and metoprolol might be preferred over others if a beta blocker is needed.
And is there one that's least preferred?
Yes, atenolol is specifically highlighted as the least preferred beta blocker during pregnancy due to studies consistently showing the highest observed risk of SGA associated with its use. So generally avoid atenolol if possible.
Good to know. Labetalol preferred, atenolol least preferred. Finally, just to reiterate clearly for the listener, which common heart failure medications are strictly prohibited during pregnancy and why?
Right, this is critical. Due to definite or highly probable adverse fetal effects, several major drug classes used commonly in non-pregnant heart failure, patients get a Class 3 recommendation, meaning they are not recommended and should be stopped, ideally before conception. These include the ACE inhibitors, like ramipril and elapril, and the angiotensin receptor blockers, or ARBs, like losartan, valsartan.
Why are they out?
They are known teratogens, particularly causing problems in the second and third trimesters. They can lead to oligohydramnios, low amniotic fluid due to fetal kidney damage, and other developmental issues.
Okay, ACEs and ARBs definitely out. What else?
Similarly, the newer class combining an ARB with a neprilysin inhibitor, the ARIs, like sacubitril valsartan, are also Class 3 not recommended, based on the ARB component and lack of safety data. And finally, the newest major class of heart failure drugs, the SGLT2 inhibitors, like dapagliflozin and palagliflozin.
They're out too.
Yes, they are also currently Class 3, not recommended during pregnancy. While the human data is still quite sparse for SGLT2 inhibitors, their mechanism of action involving glucose handling and potential effects on fetal development, plus the lack of clear safety clearance, means they are contraindicated until proven otherwise. Hydrolysine and nitrates can often be used as alternatives for afterload reduction if needed.
Okay, so the PHT's intensive management gets the mother and baby through pregnancy and delivery. But their mandate doesn't end there, does it? The guidelines seem to stress a really crucial paradigm shift, thinking about adverse pregnancy outcomes, or APOs, not just as pregnancy complications, but as important markers for the mother's future cardiovascular health.
Absolutely. This is a huge emphasis in the 2025 guidelines. It's about connecting the dots between pregnancy events and long-term maternal health.
How does the task force define APOs in this context, and how do they function as that long-term risk indicator?
APOs are defined as a group of conditions that complicate pregnancy. The key ones highlighted are gestational hypertension, preeclampsia, which is more severe hypertension with organ involvement, gestational diabetes mellitus, GDM, and preterm birth, delivery before 37 weeks. The crucial shift in thinking is that these aren't just isolated obstetric problems. They are now explicitly viewed as interrelated disorders that likely share underlying pathological pathways, often involving things like endothelial dysfunction, inflammation, metabolic dysregulation.
So pregnancy is like a stress test.
Exactly. Pregnancy acts as a natural cardiovascular stress test for the woman's body. If she develops one of these APOs, it's essentially like failing the stress test. It serves as a powerful warning sign that she is at significantly increased risk, sometimes double or triple the risk or even higher, for developing chronic cardiovascular disease like hypertension, coronary artery disease, stroke, or heart failure much later in life, maybe decades down the line.
And this understanding leads directly to a very strong recommendation for follow-up.
Yes, it leads directly to a strong, long-term Class I recommendation. It is considered mandatory for women who have experienced any significant APO to undergo a comprehensive cardiovascular risk assessment postpartum and periodically thereafter.
This can't just be missed or fall through the cracks in primary care?
It absolutely cannot. The obstetrician or PHT needs to clearly communicate this future risk to both the patient and her primary care provider for long-term surveillance and risk factor management.
Let's focus specifically on gestational diabetes mellitus, GDM. What is the specific long-term risk after having GDM, and what follow-up schedule is required according to these guidelines?
Women who develop GDM during pregnancy face a sharply increased risk of developing overt type 2 diabetes later in life. The estimates vary, but it's often cited as up to a 7-fold increase in risk compared to women who did not have GDM. It's a major predictor.
7-fold increase, that's huge.
It is. Because of this very high conversion risk, the guidelines recommend two specific mandatory follow-up steps for women post-GDM. First, a formal oral glucose tolerance test, OGTT. The same kind of test used to diagnose diabetes outside pregnancy must be performed 6 to 12 weeks postpartum. This is to check if their glucose intolerance has resolved or if they actually have persistent impaired glucose tolerance or even overt diabetes already.
And after that initial test?
Second, even if that initial postpartum test is normal, they must have repeat assessments for diabetes screening, usually with fasting glucose, or HbA1c performed at least annually thereafter. They need vigilant, lifelong screening for the onset of type 2 diabetes.
Okay, annual screening for life after GDM. Switching gears slightly, let's talk about lactation. Surprisingly, perhaps, the guidelines emphasize potential long-term benefits of breastfeeding, not just for the baby, but for the mother's cardiovascular prognosis. What evidence supports encouraging breastfeeding from a cardiac perspective?
Yes, this is a really interesting and positive point. The evidence increasingly supports encouraging and supporting lactation whenever possible, even in women with cardiac conditions, provided their medications are safe. Beyond the obvious benefits for infant health, lactation itself seems to foster the recovery of the maternal physiological systems after the stress of pregnancy and delivery. More specifically, studies have shown that breastfeeding, particularly when sustained for longer durations, like up to 12 months cumulative, is associated with a statistically significant reduced future risk of the mother developing cardiovascular disease, things like hypertension, heart attack, stroke, and even reduced all-cause mortality later in life.
Really? What's the proposed mechanism for that?
It's likely multifactorial, but one proposed mechanism is that the hormonal milieu of lactation and perhaps the metabolic demands are linked to a sustained, subtle lowering of blood pressure in the months and years postpartum compared to women who don't breastfeed. This sustained lower BP could contribute significantly to better long-term vascular health. It's quite fascinating.
It really is. Now, regarding drug safety during breastfeeding, which common cardiovascular medications are generally considered safe for the mother to continue while lactating?
This is obviously a major concern for mothers who need ongoing treatment. The good news is that the majority of commonly used and necessary cardiovascular medications, particularly the preferred beta blockers like labetalol, propranolol, and metoprolol, are considered compatible with breastfeeding.
Why is that?
Because studies have shown that the concentration of these drugs that actually gets into the breast milk is consistently very low, and therefore the dose the infant receives is minimal and unlikely to cause adverse effects.
Okay, most beta blockers are fine. What about other drug classes? Immunosuppressants?
Yes, even essential drugs like immunosuppressants, for example. Calcineurin inhibitors like tacrolimus or cyclosporine used after a heart transplant should generally be continued during lactation, according to the guidelines. The levels in milk are monitored, but the balance of benefit strongly favors maintaining maternal health, preventing transplant rejection. And the risk to the infant is usually considered low compared to the risk of stopping the medication. However, some immunosuppressants, like mycophenolate derivatives, are teratogenic and must be stopped well before conception and are generally avoided during lactation, too. Always needs specialist advice.
Right, specialist advice is key. This entire structure, from preconception through pregnancy, delivery, postpartum, and now long-term risk management, it really suggests that the healthcare system itself needs to change to accommodate this kind of continuous lifelong care pathway, doesn't it?
It absolutely does. You can't manage this effectively in fragmented silos.
So what is the ultimate recommendation in the guidelines for the delivery mechanism of this complex long-term care?
Recognizing this need, the guidelines strongly identify and advocate for the development and utilization of specialized women's heart clinics.
Women's heart clinics, what's the goal there?
The goal is explicitly to break down those traditional silos between cardiology, obstetrics, maternal fetal medicine, primary care, genetics, etc. These specialized clinics would provide a dedicated hub. They ensure continuous, seamless, multidisciplinary care, making sure these high-risk women don't just fall off the map or get lost to follow up once the immediate postpartum danger period seems over.
So it's about managing risk across the lifespan.
Exactly. It's about managing that woman's cardiovascular risk profile effectively for the next 5 decades, not just for the 9 months of pregnancy. That requires a dedicated, integrated, long-term approach. And specialist clinics are seen as the best way to deliver that. #outro.
Well, this deep dive into the 2025 ESC Guidelines certainly confirms that the management of cardiovascular disease in pregnancy has truly moved into a new era of specialization and, frankly, mandatory coordinated care.
It really feels like a significant step change.
I think the core takeaways for you, the listener, have to be the now central mandatory role of the pregnancy heart team. That PHT structure is really aimed squarely at preventing that shocking 68% of death that were previously deemed avoidable.
That's the key structural change, yes.
Then there's the non-negotiable personalization of risk assessment using that refined MWHO 2.0 classification. It's not one size fits all anymore.
Much more granular.
And finally, the extreme level of detail and planning required for managing those high-stakes situations, especially around anticoagulation for mechanical valves, delivery planning, and managing conditions like aortopathies with that postpartum risk in mind. It's a monumental step forward for improving maternal outcomes.
Indeed. It provides a really comprehensive framework. However, it's also important to note, and the ESC task force itself was careful to highlight this.
The gaps.
Yes, significant gaps in the evidence still remain. Future research absolutely must address these voids to further refine care and fill in the unknowns. These guidelines are based on the best current evidence, but it's not complete.
Okay, that leads perfectly into our final provocative thought. If you had to identify the single biggest area, or maybe a couple of areas, where the PHT is still operating with insufficient data, where the guidelines are maybe less firm because the evidence just isn't there yet, what would that be?
That's a great question. I think there are probably 3 critical areas of uncertainty right now. First, as we touched upon, we still lack robust human safety data and clear dosing guidelines for some of the newer, highly effective heart failure medications, particularly the SGLT2 inhibitors and the ARNIs during pregnancy and lactation. That's a major gap as these drugs become standard of care outside pregnancy.
Right, we need that safety data.
Second, and this is crucial for that high-risk aortopathy group, the precise risk factors that precipitate postpartum aortic dissection, that dangerous peak around day 6, are still poorly understood. We know when it often happens, but we don't fully understand why it happens to specific individuals within that group, which makes counseling about that immediate post-delivery risk and deciding exactly who needs that prolonged hospitalization still challenging. We need better predictors.
Understanding the why, not just the when.
Exactly. And third, the long-term prognosis, specifically regarding the degree of LV recovery and critically the recurrence risk in subsequent pregnancies following an episode of peripartum cardiomyopathy, PPCM. That's not yet well defined. This makes counseling women who've survived PPCM about the safety of having another child very difficult. We need better data on long-term recovery patterns and predictors of recurrence.
So newer HF drugs, postpartum dissection triggers, and PPCM long-term outcomes and recurrence. Those are the frontiers.
Those are definitely key frontiers where the next generation of research and hopefully the next iteration of these guidelines will hopefully provide more answers.
Fascinating. Clearly a field that demands continuous exploration, research, and adaptation. Thank you for watching The Funnel Effect.